Thank you everyone for joining us again this morning. As always, we have a lot of information to cover today and want to make sure that we have some time at the end for public comment as well. So we will go ahead and jump right in. So the agenda this morning will be to quickly review the guiding principles, which I know everyone is very well aware of. Quickly look at the timeline and the now the eligibility for vaccine, a little bit of data review. We'll jump into some of the strategies around our phase 3 approach, cover high density communities and BIPOC update. And then we'll talk about some general vaccine updates and new information around the FDA approval for 12 to 15, and then we will have hopefully some time, protected time for public comment. So looking again, as always, we want to just share our guiding principles as they are still very important to us as we move through our continued approach to try to vaccinate every Rhode Islander with safety being paramount, minimizing morbidity, the effective and efficient distribution of vaccine, ensuring that everyone has access to vaccine, everyone who wants to be vaccinated can be vaccinated, and ensuring that equity is cross-cutting among all principles. So in looking at our, the big picture of now our eligibility timeline, we can see kind of where we were and where we are now. Up until today, we have had eligibility for 16 and older who live, work, or go to school in Rhode Island. And then we are also vaccinating people within the hospital systems who might not live in Rhode Island, people who are at, you know, a higher level of concern and wanting to make sure that everybody gets vaccinated. So we'll get a little bit deeper into the new issuance of the FDA's Emergency Use Authorization for 12 to 15, but as of this morning, this is where we are, but we clearly will need to update this, this timeline to add 12 to 15-year-olds. So that's very exciting. So if we can jump into the next. So this is an illustrative view of our progress through all of the age bands. It's always exciting to see every time we are continuing to make progress among every age group. As you can see, we've broken out the 16 to 39, so 16 to 19, 20 to 29, and 30 to 39, so you can kind of get a better view of each age band in the 16 to 39 age group. We have vaccinated more than 90% of all eligible individuals 60 and older as of May 10th. And then almost 50% of those 16 to 39 have received at least one dose. So what you see here on this chart are first dose administered, not fully vaccinated, but amazing numbers continue to grow. We know that there's still a lot of work to be done, and we'll talk about all of the strategies and would like to hear from the subcommittee about those strategies and more things that we can do to reach all of our eligible populations. But just this is a great illustration of the continued progress that we're making. Even though things might have slowed down a little bit, we're still making progress. So we're still trending in the right direction. So that's good news. Next slide, please. So to jump a little bit into the strategy overview, as we all know, supply is outstripping demand. Again, we still have demand for vaccine, which is fantastic. We want to continue to try to reach people where they are. We know that, in the very beginning, people were, lining up and tripping over each other. That's not necessarily the case now, but we know that people still want to be vaccinated. It just may be more difficult, or we need to be bringing vaccine to people, meeting them where they are. And so that's the objective of our phase 3 strategy, is to have very strong community engagement, focusing on targeted outreach to education, institutes of higher education, schools, working with businesses and workplaces, community and faith-based organizations, special events like anything happening across Rhode Island where there are large gatherings of people, so we can bring vaccine and make it easily accessible. And then of course, working with our healthcare providers and getting more vaccine into our primary care settings and other healthcare settings so that it is, we have an opportunity for vaccination within the medical home. The current progress that we have with reaching people where they are, we have developed a community partner interest form. So this is located on our website in the lower corner here. And for folks that might not be online, it's covid.ri.gov/request-vaccine-event. Anyone within the community, businesses, community-based organizations, anyone who has interest in assessing the opportunity to either bring vaccine to a location or to work with our operations team to set up opportunities for people to go to existing channels to receive vaccine, can complete that interest form, and someone from our operations team dedicated to this work will reach out and engage in those conversations to identify what the best approach is, what the needs are. But we have teams of vaccinators who are able to go out, and we can do pop-up clinics, pop-up vaccination clinics at all various types of locations. Where there are arms to be vaccinated, we're willing to go. So throughout May, we will hold industry and community strategy discussions to talk about where are all the opportunities. Not only are we asking people to contact us, but we are actually doing active outreach to known partners or anyone who brings an opportunity up to our attention, thinking through all of the places where we can vaccinate people. They will review and schedule those vaccination clinics, or again, opportunities to bring people where there are existing channels. And then we continue to review the vaccination data to help drive our approach and help to drive uptake where we see lagging numbers or areas that are just, where people are not being vaccinated, but, certainly are still interested in being vaccinated. So that's kind of a high level strategy approach to what we're doing. And it's, so far there's been many clinics within the institutes of higher education, some large businesses, but it's interesting, some of those large businesses, when looking at their actual people who have already been vaccinated, a good number have, but there might have been a pocket of people that just hadn't had the opportunity to. And so a pop-up clinic going to that business can, capture the rest of their employees to be vaccinated. So all great work. Happy to open it up if there are any questions here from the subcommittee to learn, I hope I covered it pretty well, but happy to answer any questions about the current strategy, along with, obviously continuing all the work that we're doing within our existing channels.
Tricia, this is Chris. If you could comment, I know your strategy probably isn't going to change on homebound because you've been pretty successful with it. Any update on that progress, leading into phase 3?
Absolutely. Thank you so much for that question. Yes. I just reviewed the data yesterday, and I believe of the identified population of homebound individuals, 83% of those that we identified have been vaccinated. So progress is being made. Again, of that identified population, the team expects to have vaccinated everyone by the end of May. So that's and of course, from time to time, I think there are still people being identified, and reaching out that they need to be vaccinated at home. One thing I also want to mention is that the process for that did change a little bit. If you remember, we had a survey that people could go in and complete to say, either they were a caregiver or a loved one or someone who knew, an individual who needed to be vaccinated at home, or the person themselves went on and completed the survey. What we have now is each vendor is assigned a city or town, and the list is on our website. So individuals can actually call the vendor directly now to set up their appointment. So on our website, covid.ri.gov/vaccination, if you scroll down just a little bit, you'll find the list of the vendors with email and phone number. And you just call the vendor, whatever city and town you live in, find the vendor that is associated with your city and town, and you can call and schedule the appointment directly with them.
Good.
Trish,
Great,
it's Kathy Herron.
Hi, Kathy.
Trish, I have a question. With Memorial Day weekend coming and so many things that are opening up now, have you thought about going to campground sites or beaches or things like that?
Yes, thank you. Absolutely. The team has identified state parks, beaches, all things like that, knowing, kind of places where people will start gathering, knowing that the weather is getting warmer. Yes, absolutely. Thank you. Okay. Thanks so much. So I'm going to move to the next slide, which I'm going to hand it over to Jim Beardsworth.
Hi, folks. Good morning. Jim Beardsworth from the Rhode Island Department of Health Communications Department. It's a pleasure to chat with you all. I'll keep it brief. Obviously, I know we have a lot of information to cover today, so I'll just get right into it here. Communications. I think we all know that we've hit this phase now where sort of the challenging work, if the work prior wasn't challenging enough, where we really have to get in and sort of mine that information that we need to get to the people that we know we still need to reach where they are and in their places of where they work, where they live, and where they gather. So real briefly here, you'll see three boxes that are highlighting what it is that we're doing right now, among other things, obviously, but these are the three key focuses we wanted to share with all of you this morning. Right now, one of the things we know it's a key to the work we have to do is to get some really good, tangible results into where and what and who these people are and what some of the driving issues are within their hesitancy, if you will. So what we're doing is we're going through a series of spot polling. We're expecting some of those results as early as today, and that's something we have going on somewhat of a regular basis. We also are working on some focus groups, which we're recruiting those as we speak, really today and this week, and we expect those to go into actual work next week where we get those results from those groups. And we're also going to be doing some message testing. We're going to be working with the Brown Policy Lab on that, and we're working with them to ramp up that effort. So it's really important to get this data so we can work to craft these messages and be as strategic as possible in getting that out to these folks. So with that in mind, we're looking at what the resources are, and as I mentioned, this research will drive our material generation and our communication strategy further, so we can really drill down. So that'll be really important. In addition, one of the things we've been doing in the last week and a half, 2 weeks, is working hand in hand with the demand generation team, going out and working with folks who are expressing interest in having clinics and promoting awareness and education amongst their populations, workforces, what have you. So specifically, communications is working to develop, and it really is just about completed, a customizable toolkit that we provide to these folks as they present themselves from across the education, business, workplace communities. So what that means really is they're looking to us to help, put these clinics on, and not just from the operational standpoint, they want to spread the word. So obviously comms gets involved. We work with them, understand their needs. And because we expect such a large number of responses and interest to this demand generation process, we've put together this toolkit, which has posters that they can use, print on demand, standard template emails. We'll have a standard template press release that they can use, and other things from social media and those types of programs that we know they will need to help reach their populations. So this is really important. We want to be good partners to them and ensure that these clinics will be successful as we, again, drill down to get more granular in this effort. And then additionally, just want to talk about a couple existing resources. We continue to have our community partner toolkit, which you can link to in the bottom. That's very important in providing these resources to folks. And in addition, we just launched this week a vaccine confidence flyer. This is something we've been working on over the past few weeks. And what this does really is it's got a lot of good information. It's almost done in an infographic format, but it's got some good data, good information, other additional access to research and information. And we also highlight community leaders and others, and it's customizable to the need where we can bring in other folks and other community leaders and really get to that specific layer. We're also translating it into approximately 11 different languages that we would do for our normal education materials. And we think this will really be helpful. And from what we've seen so far, it has been receiving some positive feedback as a need that's out there in the community. So with that, I will pause and I'll turn it back to Trish. I think we might have a discussion question and any other questions you may have on these topics.
Thank you so much, Jim. Before I pose the question, Dr. Lang, you have your hand raised.
Thank you very much. Just a reminder that all the strategy is wonderful. And Tricia, I heard you mention it in your presentation, but it's highlighting again the importance of the medical home relationship. We are at the point where the one-on-one relationship between the pediatrician, family doc, and internist and their patient is really going to be helpful to answer the individual questions that have come forth that prevented people from going to the clinics already. So thank you for including the medical homes in this work.
Thank you, Dr. Lang. Appreciate that.
Thank you, Dr. Lang. So we wanted to open it up to the subcommittee. We wanted to hear from you. What are you hearing from the communities in which you work? What are the other things can the Department of Health incorporate into our communication strategy? Certainly want to hear your feedback. And I see that Joan has her hand raised. Joan?
So two things that I'm hearing. One is that there's no need to get a second shot because there's a false belief that one covers you 60%. That's the number I've actually heard multiple times. So there's less motivation to get a second shot because they believe that they are covered enough. And then the second is that I don't have to get a shot because everybody else around me will get one and therefore herd immunity essentially. So I don't need to. So those are the two messages that I hear more often, particularly when we go into the homes and there are caregivers in the homes and they're not vaccinated, but we're vaccinating the patient. So trying to convince them to get it because it doesn't necessarily help the patient if those around them and caregiving aren't also vaccinated. Thanks.
Trish, can I just speak to that for 1 second? Yeah, Joan, thank you for that information. Just very briefly, I will say we've heard that and we have incorporated that into our messaging. I appreciate you sharing that though and any other insights that folks have, but good to know at least what you're hearing we do have addressed and we'll continue to elevate that message. Thank you.
Carrie, good morning.
Good morning. So two additional points to jump on to what Joan said. I've been hearing the same, but one from a younger community adult standpoint is I'm young, I'm healthy. Even if I got COVID, I'd be fine. My parents are vaccinated, my grandparents are vaccinated, I don't need it. But if it would let me take the mask off, I'd get it in a heartbeat. So that's one I hear. And then also parents, with the 12 and older, and I think that will be a discussion for another time, but their push on the people who are the parents who are a bit more hesitant is if it will get my kids back to school full time, that's really what would be the push there.
Thank you, Carrie. Yes, both very important points that I believe we've worked into our messaging, but I agree that, in thinking about, how can we get this out more further and in front of people so that they can hear it more consistently, right?
And to that point, folks, again, appreciate your, providing this info as well. I think we'll learn more in depth as we get our research back too. So we'll continue to validate all these messages, but really, really good information that we know that we have in place. We just have to make sure we get it into those right audiences and continue to beat that drum.
Thank you. Dr. Giordano Perez.
Hey there, everyone. I just wanted to comment on the fact that I know what we're trying to do at Tri-County right now is we're trying to remove as much as possible that scare factor that's associated with the vaccine, especially as we're getting closer to vaccinating our adolescents. And so we started putting staff and nurses in costumes, like big inflatable costumes, and putting them at bus stops, at the corners of streets, walking down with signs saying walk-in vaccines available. So to make it a little bit more fun and friendly. Because I think that there's just a lot of fear, especially when it comes to a needle in our adolescent population. And I think I get more a general vaccine hesitancy from my 16, 17-year-olds than I do from my 12-year-olds. So something that we're trying there. But speaking to what Joan said, those were things we've been seeing and questions and kind of misguided beliefs that we've been seeing for the last several weeks now at our vaccine clinics. I'm having a harder time filling them up. What I will say is it seems like costumes are working a little bit. We get an extra 10 or 20 walk-ins right off the buses when we try to do that. But otherwise, it is seeming like it's getting a lot harder to pull people in or to convince them that it's important for them to be vaccinated. At our health center, we've been trying to call, we're relatively small, right around 9,000 patients. But we've been trying to call every single patient personally and to speak with them over the phone to answer their questions about vaccine hesitancy or whether or not it's appropriate for them to get them in. But it's a big undertaking for a smaller health center. But I think that that's going to be really helpful, especially for our pediatric population also in addressing concerns that the parents have.
That's great. Thank you for sharing that. Love the costume. That's fantastic.
I'm not sure. The thought of a clown with a needle might be a little scary to me.
No clowns. No clowns.
Excellent. Excellent.
Okay, I'm not sure of the order here, so if I went out of order, I apologize. I'm going to start with Dr. Chowdhury.
Hi, good morning. I apologize if my dog decides to bark at the school bus right when I speak. I'm running out of material. I've tried everything, including staying in the room with my really hesitant patients, and sometimes that can make them feel better. But I do know that some businesses are incentivizing employees with, bonuses. And I don't know when we'll get to a point where we'll consider food or gift cards to Stop and Shop or something, because we're getting to a point where what's left over can be unreasonable fear. And sometimes small things can be the nudge that gets people to say yes. And then just trusted people that they know, again, in your medical clinic, or if there's your own doctor calling you, etc., may have some impact. Thank you.
Thank you, Dr. Chowdhury. We are exploring working with commerce, working with businesses and workplaces to see what kinds of incentives can be provided. We explore, have talked to other states and other partners around the gift cards and things like that. There are some ethical concerns around giving people money, in exchange for vaccination, and then also thinking about the people who already have been vaccinated and said, well, do I get one too? So we are exploring a lot of that, but I think looking at some of those more the opportunities of workplaces and businesses to try to help support incentives for vaccination, whether it's some kind of credits or reduction in, I don't know, sometimes they have wellness credits and things like that, but we're certainly exploring that and happy to hear from anyone who has, ideas on that, but we are connecting with commerce to start having those conversations. Great. Dr. Bledsoe?
Yeah, hi, Tom Bledsoe. So one thing that occurs to me early on in our presentation this morning is the idea of the state opening up or businesses opening up, but having personal opening up or personal lockdown. So announcing that the state is moving to a different phase, but if you're unvaccinated, you should stay in the previous phase. Just an idea. What I'm hearing in my office is several things, some of which have been mentioned already, so sorry if I'm repeating, but I'm being careful myself. I don't need the vaccine. Hear a lot of that. Is it safe? It's very common questions and concerns about safety. I won't get sick if I get the virus. And unfortunately, since Easter, I've had a whole bunch of patients who have gotten quite sick after letting their guard down. Which vaccine should I get? So the choices is to some extent having some analysis paralysis for folks, and there's a downside to that. I'm hearing a lot of people saying I was surprised to get sick after fill in the blank, a Easter family gathering or a small wedding. And as Dr. Lang alluded to, do you have the vaccine here today? So if I can whittle them down a little bit and they are willing to be able to strike while the iron is hot, would be great.
Yes, absolutely. All great points, and particularly the last one. Yes, getting this vaccine into primary care in the medical home, absolutely. So I'm going to go to Teresa, and then I'm going to move on to the next part of the presentation. And again, we will open it up later on. So if there are any other comments in this area, certainly feel free to bring it up. Teresa, I believe.
Good morning. Thanks for all you guys are doing a great job. Just one more to add to the list. I was thinking Tom might get to it before I did, and that is I've already had the flu. Do I still need the vaccine? We're hearing that on Fairfield. I see other heads shaking too. There seems to be some confusion that if you've already had COVID, you're immune. So just another issue for messaging. But thanks so much for all everybody's doing.
Great, thank you, Teresa. So we will move ahead here, and I will share the floor with Ingrid.
Good morning, everyone. Ingrid Gardner, HTC Vaccine Operations. So we just have a few quick slides, but you know, we have continued to see an increase in vaccinations within the community of people who are Black, Indigenous, and people of color. Although, you know, as you know, just given the decline in demand, the doses administered in May are relatively small, but the proportion that we see going to the community in the first week of May is 25%, or at least 25% actually, which is greater than our proportion, or the proportion of Black, Indigenous, people of color to the population. You can see in May, specifically, the first week of May, 19% of the vaccinations went to the Hispanic or Latino population, and that group only comprises 15% of the population. And then the 6% went to both the Black and Asian populations, and each of those groups comprise 6% and 4% of the Rhode Island population, respectively. So all in all, encouraging news in terms of the percentage of doses going to these communities. And I think we'll hopefully see that increase with some of the targeting outreach that we're doing going forward. So this slide is really just showing the changes in coverage overall to date. And as you can see, the BIPOC community continues to receive a disproportionate amount of the vaccine administrations. However, just as we just described, it's gotten better in recent weeks. So overall, we have approximately a 1% increase from April to May for the BIPOC population. That has been a slight decline for the Black and African American population. It's pretty consistent for the Hispanic population for the second doses. And then just generally overall, you know, we're starting to change the strategy for the HDC and BIPOC populations. We're referring to it as phase 3. We're still continuing to drive demand and get those communities vaccinated so that we can close the gap between the hospitalizations and vaccinations. Some of the areas that we're looking at are strategy and planning, just trying to identify different ways that we can increase the uptake, and obviously working across groups with the other vaccine channels that are also looking at the same issues across Rhode Island, and coordinating with our partners across RIDO. And so that includes, you know, the health equity zones, communities, teams, communications, to ensure that we're driving some targeted outreach to those communities. And then as we look to onboard more providers, we are still continuing to onboard medical providers and community-based clinics to support the HDC and BIPOC populations. We are also trying to look at the footprint of all the providers that we currently have and identifying areas where we think there might be cold spots, areas where we want to make sure that we're onboarding providers who will be able to support vaccines within these communities in the long term. And then a big piece of our strategy going forward is going to be that community engagement and coordinating with community leaders to make sure that we are listening to them, hearing from the community in terms of what those specific vaccination needs and concerns are so that we can address those needs in a very targeted way. Trish, do you want to ask the question?
Sure. Thank you, Ingrid. So we were interested to hear from you all on how can we better engage you as advocates for messaging within high density communities and other community efforts. We want to make sure that we're, obviously, your time and your expertise on the committee and all the work that you're doing in your professional lives and social lives, but we just want to hear from you on how we can better engage with you to be advocates for this vaccine messaging within these communities.
Look, Dr. Bledsoe, would you like to start?
Yeah, sure. So each of us are great representatives of various segments, but there are also lots and lots of people like each of us. So, for example, the Medical Society stands ready to continue to push at every encounter. So, if every doctor had something very quickly at every visit and a vaccine available down the hall, that's a lot of vulnerable people. But for the schools to have every teacher, have every family, and so on, just to try to roll that out as broadly as possible. Each of us has representatives of larger groups.
Thank you. Wendy?
Hi, good morning, everybody. This is Wendy Chacoin. So I just kind of wanted to share just quickly, Providence Community Health Center has done to try to engage and, educate patients. We actually established pretty early on what we call a vaccine confidence committee. And so we have, providers who are engaging with the community members to just kind of give talks and educating the community. Also events, just having our providers go out there and kind of really discuss the vaccine, address some reasons for hesitancy, and then also Spanish radio. So we've been actively engaging in those ways of, trying to get the message out to communities. One other thing I just wanted to add, just kind of thinking about under the strategy and planning, I'm sure this is something that's already been discussed, but, understanding maybe what the barriers are. I could just speak, for some of our patients. I'm not sure if there's been any discussion about, I know going to the workplace, but just thinking about where this particular population may be working. And some of the challenges, even just for getting to primary care, is just that their hours of work. So sometimes our patients work very, very late, or they work overnights. So I just want to kind of bring that forward. It's probably something, again, you've already thought about, but just thinking about how can we go to where those patients are, and just thinking about the flexibility and making sure that it's not a barrier as far as, their times of work. So just something I want to bring forward.
Absolutely. Great points, Wendy. And yeah, I do, I think that the teams are thinking about that, but I think to hear it again is critically important. So thank you.
And Wendy, if you could refer patients to that community-based form, if they have coworkers who are also unvaccinated, we are happy to send our vaccination partners out at all times of day or night in order to achieve vaccination. But unless we know where they are, it becomes, that's our significant barrier. So if you wouldn't mind sharing that as you hear about, especially, locations where there are multiple people who need to be vaccinated, that would be tremendously helpful.
Okay, great.
Trisha, I just wanted to jump in and bounce off of what Wendy had just said there. It just reminded me that I had a few patients come in just last week who were mechanics, and they were coming in with their family members who were getting vaccinated, but they weren't getting vaccinated themselves. And when asked, it was because they could not possibly miss tomorrow and they heard either their arm was going to be dead sore and they would not be able to work, or they would be sick the next day, and that there's no way their boss would ever let them, some of them being off the books and being paid under the table, there's no way that they would be excused from a day of work. So just immediately came to my mind, if there was any way, if we don't necessarily incentivize the individual, but if we incentivize the employer to get more of their staff vaccinated, that would also help maybe kind of create a different feeling within the environment to say, no, I want you to go ahead and get your vaccine if you're sick the next day, or I mean, if you're having symptoms the next day and you feel under the weather and can't come into the clinic or can't come into your workplace, and or your arm is too sore, whatever it may be, that's okay. We'll cover you for that day for your pay, and you go ahead and just stay at home while you kind of get back up to your normal self. So I don't know if that's at all possible. To go ahead and incentivize employers that way, and or provide employers with funding in any way to actually cover the cost of having one of their staff members out for a day or two in these kind of harder hit employment situations where they're really not willing to let people stay home.
Yeah, I know that's a conversation that's been had, but I think you're right. So it's, would the employers just be willing to do that? And if not, do we have the ability to provide any level of compensation for them to do that? I know those conversations are started. I don't know if we've landed anywhere yet, but we certainly will continue to go down that path, because I do agree that would certainly provide that comfort, and knowing that, that they have the support of their employer and the ability to miss a day if they have to and not lose any wages due to that. So we will add that to the list, working with the businesses. I'm not sure if anyone else from the Department of Health team has anything else to add in before we move forward.
There are, one of the challenges is the size of a business. So there are funds available if you're willing to go through all of the rigmarole and the paperwork of essentially accessing FMLA for any of your employees. The challenge is there's no low-hanging fruit. There's no very simple solution that just says, I have X number of employees, we're going to give them each, 1 day off to recover post-vaccination, and we will, again, we'll recoup those costs for that paid time off. So that was something that was raised to us by one of the trade organizations that there's not a simple solution for, but that we are discussing.
It's Tom Bledsoe again. The time out of work for getting sick is so much greater than potential time out of work for getting a vaccine side effect that it's a shame if employers, well, I guess that's an opportunity if employers need convincing of that kind of mathematics.
The bottom line. It's the bottom line. That's all that matters. Yeah.
Okay, thank you all so much for the great conversation and input and ideas. So I'm going to move to the next slide here. So as we've discussed earlier, we are working to onboard primary care providers to receive and administer COVID-19 vaccine. This is, we kicked this off last week, and even with the development of this slide, the update that I received late yesterday was that we already have 16 practices that are fully onboarded, and just working with them on when they will actually, the timing of when they'll receive the vaccine. So a few considerations here. We did start the rollout with pediatricians and family physicians. And one of the first things we do is we need to make sure that they're certified and already enrolled in the state supplied vaccine program, which pretty much every healthcare provider that sees children is enrolled in the state supplied vaccine program. And of course, we have many adult practices as well. So it's one of the first things that we do. A survey was sent out to roughly 140 practices to assess interest, because not everybody is interested in going this route and or has the ability to implement the administration of COVID-19 vaccine for one reason or another. But we wanted to assess interest, assess the on-site operational plan for that practice, thinking about the storage of the vaccine, ways to minimize waste, because of course we know that we're dealing with multi-dose vials, and in particular the Pfizer vaccine has more limitations around storage than the other two vaccines do. And with this setting, of course, Pfizer will be critical so that they can provide vaccine to those 12 and older. We have a provider call center that had administered the survey and is working directly with the practices to kind of talk through the operational planning to receive vaccine. It will need to be in a clinic-like setting, if you will. So it's going to be different than just having, you normally have flu vaccine in your office and it's pre-filled syringe, and as people want the vaccine, you can give it. It's not, we can't quite do that this way with the multi-dose vials. And in particular, again, with Pfizer, practices will either need to administer the vaccine within 5 days if they store it in the refrigerator, or administer it within 2 weeks if they store it in a standard freezer. So kind of working through all of those processes with the primary care offices to get them going to have vaccine available. So we are working to try to onboard and get people, ready. Probably like 5 to 10 a week. We will scale that up as we can. Some practices will be will easily be able to kind of have everything ready to go, and some might take a little bit more time. One of the other pieces of this is just making sure that the data reporting is successful. So ensuring that all doses that are administered within that setting can be submitted to our immunization registry within 24 hours. And that all the data comes through. A little bit of testing might need to happen to ensure that capability is there. But again, most of these practices are already doing that on a regular basis, but we just need to make sure that it's timely. We can't wait a month before we receive the data. It has to happen daily. So we will continue to roll this out to offices. Again, we have a provider help desk. I can put the information in the chat in case that's needed. There's an email address and there's a phone number in case you have questions or you need to talk through some of the operational planning that goes around this. One last thing is that the vaccine will be redistributed. So as you can imagine right now, not only multi-dose vials, but the minimum order for these vaccines is still relatively high, very high right now, with Pfizer, of course, being 1,170 doses per order. So we have to break up trays and have it redistributed to the offices based on what they believe their needs are. Some patients may already have been vaccinated, so offices need to kind of go through that to see who's already been vaccinated and what their vaccine needs will be. So we're really excited about this. Again, I'll put the information in the chat, but more to come, and we're going to try to get this vaccine out to every primary care provider as quickly as we can. Let's see. So I'm going to jump into the latest information that everyone, I believe, received yesterday around the FDA's approval for emergency use authorization for 12 to 15-year-olds. So just first, I wanted to mention that Pfizer did apply for full FDA approval for their vaccine. Again, this is the BLA. It's the biological licensing authorization. That's anticipated to take several months, but I just wanted everyone to be aware that they have officially filed with the FDA for full approval. As we understand it yesterday, the FDA has announced emergency use authorization for the vaccine for 12 to 15 years of age. I'm sorry, I was just pulling up information that we received from the federal, our federal entities. So so we had a discussion with you all at, I think it was 2 meetings ago, where we discussed as a group, and after hearing from a few of the pediatricians, that we wouldn't have to have an emergency meeting to move forward with rolling out the vaccine to 12 to 15-year-olds, that we would be able to do it upon FDA authorization. So our plan, after hearing the announcement yesterday, is that we're going to move forward today with updating our systems, our registration system, the consent form. Obviously, we've done a lot of back-end preparation for that already in anticipation of this, but we're going to effectively move forward and make those changes so that parents and guardians can begin setting up appointments for 12 to 15-year-olds. We have received guidance from the Department of Health and Human Services, our federal entity, that all states should be, upon FDA emergency use authorization, should move forward to make all individuals eligible for the vaccine as soon as the FDA makes that authorization. So that is our plan. CDC's Advisory Committee on Immunization Practices is convening tomorrow. They had preset the meeting in anticipation of this announcement from FDA. So they're meeting tomorrow between 11 a.m. and 5 p.m. to discuss the 12 to 15-year-old vaccination. We don't anticipate anything, flags or any concerns from the ACIP. One of the things that they are discussing is co-administration of the vaccine. Right now, as it stands, the recommendation is to not vaccinate with any other vaccines 14 days before or after COVID vaccination, but they are discussing co-administration. So there is a possibility that that can change, which would be great. That would be much easier for healthcare providers if they didn't have to worry about co-administration, but we'll see what comes out of that. We are coordinating with the Department of Education to coordinate with municipalities, the cities and towns for their school clinics. As many of you know, the school clinics have kicked off in various locations for the 16 to 18-year-old population. So we are coordinating with the Department of Education and the schools to see which are able to incorporate 12 to 15 as well, or whether that are interested and able to incorporate 12 to 15-year-olds into those clinics. And then the Pfizer vaccine will be available to 12 to 15-year-olds in all existing channels. So our mass vaccination sites will be open to 12 to 15. The pharmacies, of course, have been authorized by the federal government and through the PrEP Act to provide vaccine to 12 to 15-year-olds as well. So that's the plan. I'd like to open, but before I jump into AstraZeneca, because this is kind of at the forefront here today, interested to hear any feedback, questions, or comments from the committee.
This is Dr. Lang. I know there's a piece on CNN about just before our meeting started that some states are actually opening up today to the 12-year-olds before the ACIP recommendation. What timeline is Rhode Island thinking of having 12 to 15-year-olds available? Are we waiting for the ACIP recommendation likely tomorrow?
We are not planning on it based on that federal guidance that we are to, as soon as the EUA was issued, that we are to make it eligible for for 12 to 15-year-olds. We do have a little bit of work to do today to get the system in place to make sure that the updated EUA is in the registration system and that the consent form is updated and any other language needs to be presented. But my understanding and other of my team members on the phone here, I think by the end of the day today, we could have everything ready to go and people can effectively start scheduling appointments. Does anyone have any feedback from the RIDO side?
That's what we're working on right now. Again, there are a number of electronic systems that need to be updated in order to ensure that people are screened appropriately and that the messaging is clear about it's only for the Pfizer vaccine. So only clinics that are offering the Pfizer vaccine will be able to vaccinate down to age 12. We suspect, there was a letter that was issued from HHS last night that indicated that everybody should open with FDA authorization and that there was no reason to wait. So we expect that our pharmacy partners, because they're receiving vaccine directly from the federal government, will start updating all of their systems today as well. So vaccines should be widely available to those 12 and older by the end of the day today.
Yes, thank you for that too. We certainly welcome input from the committee on implementation and how to do that most effectively. It is a little bit different from previous approaches, but knowing that every day matters, knowing the federal guidance, and knowing the team's readiness to go forward and the fact that the ACIP is unlikely to change anything significantly. We'd like to push and get as many youth vaccinated as quickly as we can start.
Trish, do you know if there's going to be any difference in the consent form for the adolescent or pediatric population? I'm not advocating that there should be. I just wanted to know if there was.
I don't know. I don't believe so. Everything stays the same pretty much in terms of assessing contraindications. Great. Okay, so if just to provide for awareness, so AstraZeneca had applied for FDA Emergency Use Authorization, and I guess more recently the FDA has requested additional information from AstraZeneca based on their application. So AstraZeneca's application is now being estimated that it may, or emergency use may come through by mid-May for this vaccine. So it's a slight delay from the previously anticipated mid-April timeline. So really wanted to hear from you all on, once AstraZeneca does reach FDA Emergency Use Authorization, what your thoughts are on moving forward with that. Would you like us to hold an emergency meeting before we do anything else, kind of moving along with the same approach that we did with the previous approved vaccines? So really interested to hear your feedback on how we move forward with AstraZeneca, if at all.
This is Tom Bledsoe again. How's our supply look if the AstraZeneca was never used in Rhode Island? Is it likely that we'll have enough vaccine for everybody without needing it?
It seems so. We definitely have ample supply right now. So I'm kind of to your point, I'm not sure if an additional vaccine, but I guess maybe the thought is having more options, but I just don't know what the some of the information is that's coming out about AstraZeneca and what the efficacy is and all of that. I'm not sure if it's any different than the others.
So a little bit of a bold suggestion that's maybe outside of our charge, but if it's approved, making a statement that we're happy to hear that it's safe and that the state of Rhode Island recommends that the United States send our supply across to another country outside that's short of a vaccine.
Thank you, Dr. Bledsoe.
I'm actually quite serious. We have what I said before about too many vaccines and too many choices. There's a downside to offering another one, especially if it has had some questions. If it's declared safe, we're not sending our junk abroad, but making a statement.
Absolutely, and we've actually heard that in just talking with our colleagues in other states that that is something that needs to be considered by the federal government and advocated potentially by the states. Absolutely. So we certainly, go ahead.
Karen Tashima. Yeah, I think it's gonna be similar to the Janssen in terms of the side effects. So, I think that we have to be clear about that. And wherever we are with the Janssen, it's gonna be similar.
Right, absolutely. So what we'll do is, once that, we'll continue to track the progress up until the EUA is issued. But once that happens, we will, we might have a meeting on the books already, but we'll make sure that we have a meeting specifically to discuss it before we move forward.
Hi, Tricia, it's Wendy Chicoine. I agree with that. I mean, personally, I'd like to be able to kind of read, the data like we did previously for this particular vaccine. That's just my opinion.
Absolutely. Thank you, Wendy. Okay, so I let's see, we've got about 4 or 5 minutes left. So I'd like to take the opportunity to open it up to public comment. So for anyone who is interested in providing public comment, if you can put your name in the chat, and then Erin will promote you to panelist, and then she'll, call out your name. You'll have 1 minute to make your comment, and then once you're finished speaking, you'll be put back to an attendee mode, and then we'll get through as many people as we can in the short time that we have left.
And in the meanwhile, Tricia, can you answer Chris Ariano's last question regarding 12 to 15-year-olds?
Let's see, so I'm sorry, I was just reading. A legal guardian needs to sign the consent form, but does not necessarily need to be present for the vaccination. However, we do recommend that specifically at our mass vaccination sites, but it's not a legal requirement that they are present.
Thank you very much. Just want to be clear when we're passing information on to our members and patients. Thank you.
Absolutely. Thank you, Dr. Ariano.
And just to bounce off of Dr. Ariano's comment, I just want to make sure, do we need to do any due diligence on our part to confirm that this is a legal guardian?
My understanding from our legal team is that if someone signs off that they are attesting to it. That's really all you can do.
Okay, thank you.
Okay. Erin, do you want to? I think Katrina Bird has,
Yep.
Okay.
She's been promoted, yes. So Katrina, if you're able, you can go ahead and go off mute.
Yes, hi, this is Katrina Bird. I just wanted to say that I was part of the group that coordinated medical volunteers for the Dunkin', like the mass vaccinations at Dunkin' Donuts for BIPOC communities. And one thing that I think the state in Rhode did a wonderful job, but one thing I noticed in the last weekend was the lack of communication. There were so many people who didn't realize that you did not need an appointment for the state-run vaccine clinics. People didn't know, like they were still nervous about using ID or being asked about immigration status. So some of the basic communications really aren't trickling down to the BIPOC community. And so I'm happy to hear that, there are going to be greater efforts, but even basic messaging is still not getting through. So one recommendation or one thought I had was possibly having commercials on TV, reaching out to Spanish-speaking radio stations, so forth and so on. Thank you.
Thank you, Katrina. We will certainly take that back to our communications team and others to make sure that we're getting that information down to the ground level. That's very important. We don't want people to be concerned with getting vaccinated and having to worry about IDs and understanding that they can just walk into appointments. Thank you. Anyone else who'd like to provide comment, if you just put your name in the chat?
Tricia, can I jump in for a minute?
Absolutely, Dr. Tashima.
I wanted to talk to the subcommittee today about the Novavax study participants. So similar to AstraZeneca, there are study participants who are in these studies and receiving, and now the Novavax participants have received the Novavax vaccine, but they, since we don't have EUA approval for it, their vaccine status is somewhat in, in sort of this in-between state because Novavax is still considered an investigational vaccine. So I wanted to see if the subcommittee had some thoughts on this. We know that the UK data from the phase 3 study of 15,000 people showed 90% efficacy. So it looks like it's going to be a very safe and effective vaccine. It's just the problem with getting to the FDA for EUA approval seems to be more on the supply side. So the Novavax has, I think that they're going to submit to the FDA either second or third quarter of this year, and the supply is somewhat delayed. So we may not get enough supply until end of the year. So that's, I think the Novavax study participants are still contributing important information to the study in terms of how long their immunity is lasting and further safety. But so far, it looks like it's a very good vaccine. So, I think the study participants are, I'm going to give them a card that says that they've been vaccinated. It's not the CDC official COVID vaccine card. It is a card that says that they've participated in an investigational study.
Karen, and I would think, Carrie LaPlante, the why behind this, even though, the CDC is clear on who's vaccinated, is perhaps the limitations that these patients who volunteer to be in these clinical trials are going to have to experience, especially if employers are asking them to be vaccinated or they're not unmasking in public situations. These are generous people volunteering to be in the clinical trial that are kind of stuck in limbo, not having that vaccination status, right?
Correct. Right. So I think it is going to be up to the employers to accept or not accept their vaccination status. And, I'm happy to explain it on a case-by-case basis, like that, I don't encourage any of these participants to go get another vaccine because I feel that their vaccine that they received through the study is good enough. It's, the WHO has said that AstraZeneca is a good enough vaccine for people in the US. So, or the CDC accepts the WHO approved vaccines, even if AZ has not been approved here. But, I think it's trying to increase education around this, around the fact that there are people who have received another vaccine that's still in the process of becoming an EUA approved vaccine.
And is there word, Dr. Tashima, on how other states are also applying this, knowing that it is national and there's opportunity for us to align?
That's a great question. And no, I have not heard of other states, giving out this kind of information. That I did write a letter to the editor in the Wall Street Journal, so that did get published. But I'm trying to advocate on a national level as well.
Well, thank you for your leadership. So we're glad to partner with you.
Sure. Thanks.
Yeah, I think it's incredibly important.
Thank you. Okay, thank you. So I know we're at time. I just wanted to end with some very impressive milestones and to thank you all for the incredible work that you do every day. So with the federal entities included, meaning Department of Defense and Veterans Association, when you put their data together, Rhode Island has administered over 1 million doses of COVID vaccine to date. 67% of Rhode Islanders are at least partially vaccinated, and 51, more than half of Rhode Islanders eligible, are fully vaccinated at this point. So amazing work. I know we still have a lot more to go, but we are tracking very good in terms of our coverage rates. And I just want to thank you all so much for helping us get to where we are today. So thank you and have a wonderful week.